So I'd like to welcome everyone. My name is Eric Shikatano. I'm a reporter with the Daily Item in Sunbury. We're joined today by experts from Pennsylvania, and we're expecting a few guests from Maryland and Ohio as well. Today's forum is going to focus on rural healthcare and the issues facing patients and providers. So I'm hoping we could just go around the Zoom call really quickly just to tell us your name, your position, and who you're with, because I know there are a lot of faces on here who are unfamiliar with each other. Billy, we'll start with you.
Great, good. Billy Oglesby, I'm the interim dean of the Jefferson College of Population Health at Thomas Jefferson University.
Thank you, Billy. Kendra, can you please introduce yourself?
Sure, I'm Kendra Ocker. I'm the president and CEO of Evangelical Community Hospital in Lewisburg.
And Mr. Lopatovsky, how about you?
Yes, Dr. David Lopatowski. I am the Chief Medical Officer of UPMC in the Susquehanna region.
Mr. Kurtz, could you please introduce yourself to us?
I can. I'll have the distinction to have the longest name of the institution. I'm the CEO of the Chan Soon Chong Institute of Molecular Medicine and Medical Center of Wimber, Pennsylvania.
Tina, how about yourself?
I'm Tina Staszewski. I am the Vice President of Business Development at Ashtabula County Medical Center in Ashtabula, Ohio.
Thank you, Tina. And Karen?
Good afternoon, everyone. It's good to see some familiar faces. I'm Karen Murphy, Chief Innovation Officer at Geisinger.
And the rest of the faces you see here are editors and reporters with CNHI, and we'll introduce some of them along the way as we ask questions. Of course, our guests represent hospitals in the respective coverage areas of multiple CNHI publications, and they're teaming with the Daily Item for a series of stories about rural healthcare. So we've got a lot to talk about. The goal here is to identify solutions to challenges to transportation, telemedicine, telemetry, medical specialists. I want to direct our first question to Mr. Kurtz, and anyone else on the call, please feel free to jump in with your insight. Mr. Kurtz, what are the biggest threats to the fiscal viability of your hospital, and what steps are you taking specifically to overcome these issues?
This will take about an hour. No. You know, it's like I'm preaching to the choir. I look around, I see a lot of familiar faces. Hi, Karen, by the way. You know, anybody that's dealing with rural health knows what the challenges are in rural health. We deal with a triple whammy. We have an older population, a sicker population, and by and large, a poorer population. So, and I can tell you the trends that are happening in the country. We're losing rural hospitals constantly. I think we lost 17 or 18 just in 2020. We lose 13 a year, normal year. And COVID really points out the strengths of the organization, also points out the weaknesses. And I think COVID really stressed the financial weaknesses in these institutions. Before COVID, I think well over 50% of the rural hospitals in this country were operating at a negative operating margin. So COVID pushed a lot of them over the edge. There were a lot of distress. And one of the things that it actually did was prove that, you know, rural hospitals need to be in existence to take care of pandemics like this. And, you know, we've always had a history of being paid less than our urban counterparts out there. You know, and again, with a poorer population, we have a lot of bad debt sitting in these organizations. High deductibles, high co-payments, or the death of a lot of small hospitals. So you look at the financial things that got exacerbated during COVID. One of the things we did here prior to COVID is we joined the Pennsylvania Rural Health Model. And that literally saved our hospital through COVID. That's a global payment system. We protected 70% of our revenue was paid on a global payment system, regardless of the volumes. At the height of COVID, we were down almost 80% in our volumes through voluntary elective and just the natural progression of people not coming to the hospital. But 70% of our revenue was protected. So models like that are going to be the salvation of rural hospitals. You need to get away from these volume-based payment systems in rural hospitals and get into a value-based thing. There's where rural hospitals really compete. They'll have value, quality, efficiencies, but not the volume. And that's what's it. But I really do think that that was the biggest thing we ever did through this year. It's 19 of us now in Pennsylvania in that model. And they're all relatively small hospitals are in it, but I really do think that's going to be a salvation of rural hospitals.
Mr. Lopatovsky, I'd ask the same question of you. What are some of the bigger threats to your own operation, and what steps have you taken to address them?
I think it's similar. You know, we have more government payers, and we know that that's not where our margins come from. They come from commercial payers, so we're impacted by that. It's the providing the state-of-the-art care in a smaller community where you don't have the economies of scale. So as we have 2 robots, we have a very advanced IT system, advanced state-of-the-art cancer treatment. These technologies, the equipment, the technologies, the staffing are increasingly more expensive every year, but yet the revenue is flat or declining. Medicare is committed to stay the same. We know everything else goes up, the rates that we have to pay staff, the amount we pay for medicines, et cetera. So it's the smaller scale, it's the cost increase and the revenue doesn't. I would also say additionally, you know, our core market here in Williamsport and Lycoming County, it's the largest county in the state, not as much of a stress point, but, you know, we have 3 critical access hospitals. We have 2 up along the New York, Pennsylvania border in Potter County and Tioga County. And then we have another one to the east of Williamsport in Muncie. And again, smaller populations. So we're providing very advanced inpatient, outpatient services in ED that does not have high volumes, but that staff is there being able to function 24/7, 365. So having all that infrastructure, but not having the volume is sort of the mismatch that I think is not fully appreciated when you compare the rural environment against the urban environment.
Mr. Oglesby, I see you nodding your head in agreement a lot during this discussion. Are these themes that you've heard a lot in your own work?
Oh, absolutely. And I think another consideration on top of what has already been said is that rural hospitals are also taking care of sicker patients. There are fewer access points, which means patients are delaying receipt of care, which means by the time they get to a healthcare provider, their disease progression is often longer. That's also driving higher mortality rates. And not by a little bit. When you just look at the 10 leading causes of death in the United States, rural residents are more likely than urban residents to die for 5 of them. And the numbers are huge. That's 71,000 more rural deaths that could be potentially preventable than their urban counterparts. And even when you look for risk factors like diabetes prevalence, obesity, smoking, all of these are disparities that you see in rural areas that are complicating the ability of hospitals to provide this care on top of all of the other regulatory and financial barriers that stand in their way.
Before I ask about solutions to issues like transportation, Chip, I know you wanted to bring up revenue models.
Yeah, we kind of nibbled at it there with a couple of those answers. I'm just interested from a couple of perspectives what revenue models are working, what you think are sustainable going forward. Maybe Bill could start us and we could go from there. But I think that's an important thing for those of us on the reporting side of this to try to understand.
Yeah, I'll start out. I mean, I think one was already mentioned. It's a demonstration project that CMS is running to look at value-based approaches for rural hospitals. This one happens to be a global payment. There are other mechanisms to be able to pay for healthcare services. I think frankly, there's too little attention paid to financing healthcare, broadly speaking, within rural areas, because even what is available for some of the demonstration projects for rural hospitals is really a drop in the bucket compared to all of the programs that the federal government has trying to figure out optimal ways of financing services for the broader community and certainly in urban areas. So while I think it is a good step, it's really only one step, and significantly more innovation and investment needs to go into payment reform for rural hospitals.
Hi, could I step in here for a second?
I was about to throw it to you as a
Thank you.
Yeah.
Thank you. Thank you. So it's a pleasure to be here today to talk about what is clearly my passion. And I started this work when I was Secretary of Health in Pennsylvania in 2015. And I always tell the story that when you assume the role of a Secretary of Health, your time is limited and you really want to make a difference. And when I looked at Philadelphia and Pittsburgh, I knew they didn't need my help. But when I looked at the rural communities in Pennsylvania, I was astounded at the financial challenges and truly the lack of access of healthcare across Pennsylvania rural communities. So we started to work on the Pennsylvania Rural Health Model, which is a collaborative effort between the Department of Health in Pennsylvania and the Center for Medicare and Medicaid Innovation. It is the first national model that transforms payment to rural hospitals. And I think the foundation, and I'll tell you, it made my day to hear that the Pennsylvania Rural Health Model saved a hospital. So that I'll take, that will make my week, not just maybe the year. But our intent really was not only to change payment, but it was to transform what rural hospitals look like and how they deliver care to their communities. All rural communities are not the same. So, we mentioned Potter County. I mean, you go to Potter County, there's little broadband, they have transportation issues, truly a deep rural community. And then when you look at Danville and you look at Susquehanna UPMC, I know Kendra's on the line for EVAN. While we're close to rural communities, we still have assets that are completely different than that hospital in Potter County. So our goal was really to provide a mechanism where rural hospitals were not counting on heads in the beds for reimbursement. In a fee-for-service model, you're paid for what you do, not how well you do it. So we wanted to shift from that fee-for-service model to a global payment, which had been in place in Maryland since 2013. And really had started many years before that in rural hospitals. And this allows rural hospitals to really serve their community needs based on what the community needs are. So it is a global payment where hospitals receive a fixed fee every month. So they have a sustainable business model and cash flow to enable them to change and transform their organizations into a much more sustainable healthcare delivery. I would also add, while the model is not perfect, that we do have to evolve the model, but I think to raise the level, it raises the level of conversation because as many pointed out, rural hospitals are essential. You shouldn't be geographically disadvantaged to access to healthcare because of where you live. But we have a lot more work to do on rural health. And I'm just pleased that we're having the conversation that we are today and that the national attention is now seriously focused on improving the health status and the healthcare delivery in rural communities.
I'd like to move on to the issue of transportation, and I'll go to Tina and Kendra. Tina, first, can you talk a bit about the transportation issues you have? And aside from telemedicine, which we'll touch on coming up, what solutions exist to help patients get to their appointments?
Sure. So Ashtabula County definitely has a transportation challenge. It comes out in every community health needs assessment that we do as a hospital, that our two competitors do, and that the county does when they do their community needs assessment. We actually offer a shuttle service that is in collaboration with the local ambulance service, and it fills up faster than what we have available slots for. It is free of charge. You do have to be coming either to the hospital for an appointment or to one of our provider offices, but we could probably run 3 shuttles and still fill it. We can't afford to run the 3 shuttles. So we do the best we can. We do not have a county full-blown transportation system. There is some public transportation that is within the city of Ashtabula, and they will do door-to-door special runs, but that also tends to fill up very quickly. So it's a challenge to make sure that patients are getting to the appointments that they need so that they're maintaining their health, as well as, you know, maybe heading off something before it gets worse.
Kendra?
Sure. I mean, I think the statistic in this region is that about 9% of households in what we consider our territory, our service area, do not have access to vehicles. And then you look at the aging of the population, and we struggle with exactly the same thing that Tina talked about. You know, we rely on things like, you know, rapid transit and some of those types of programs to help our people get around. We've been looking at, we struggle with movement of patients when they're in the hospital, even getting people home. It isn't even always about, as she discussed, getting people here. It's like your ability, especially like during this crazy time that we've been having, getting people out of the hospital. People don't have a ride home, you know, so we've have transportation vehicles that we can use to transport people from the facility. You know, those are the kind of things we're looking at, and you rely on all the other things. Bucknell has zip cars, you know, people are using those modes of transportation. But in our areas, we don't have a lot of Uber or Lyft or any of those kind of things. I think there's been some interesting models that Geisinger has used in sort of setting up foundation type roles in which they're funding these types of transportation means, because we have no public transportation. So certainly access is a challenge, and we are in the process of trying to figure out better ways to go about doing it. But it does take a lot of resources to do that. And you know, we just haven't been able to, you know, kind of figure it out in its entirety, because it relates so much to, you know, the lack of public transportation.
Dr. Murphy, can you describe a bit about how Geisinger has used telemedicine and how it's been implemented, and what sort of care is best suited for that?
Sure. So like everyone else, I'm sure on the phone that in the beginning, in the beginning of the pandemic, our virtual care skyrocketed. And that was really to ensure that our patients had contact virtually with their providers. And we continue to see that increase. At Geisinger, overall virtual care, what we're really studying now is, what does virtual care look like outside the pandemic? Where is it meaningful? Where does it improve outcomes? And we're actively studying that as we move forward. But I would mention that digital technology and virtual care is so critical for all the reasons stated in rural communities. But there are broadband across the country. There are broadband limitations. And I think that's another disparity in rural health, is that we have to get to the point where all patients, regardless of geography, have access to virtual care. Because I think what we found out during the pandemic, that there is a high level of service, healthcare delivery that can be offered virtually. And we need to do this for our entire rural population.
You know, Eric, if I could touch on the point that Karen mentions, because I don't think this is addressed enough. And frankly, I don't think enough of our elected representatives are held accountable for this enough, because this is not a new issue. In fact, Congress back in 1996 created a mandate and a funding source for FCC to help ensure that there was access to broadband, including and specifically rural communities. If you look at the bottom of your telephone bill or your cell phone bill, you see a little fee there that says Universal Service Fund. That's the revenue source for that. 25 years later, we still only have 63% of rural homes that have access to broadband. So, I appreciate when I hear politicians talk about expanding access to broadband within rural communities, but we've been hearing that for more than 20 years. And I think there needs to be an incredibly more diligent effort to holding elected representatives accountable for delivering on that promise, because it's not only holding back access to care, it has a huge and growing economic impact. That means large businesses who rely on high-speed data, it's harder for them to move into those areas. It's harder for rural residents to be able to access what is now a huge amount of online learning to help them either get a promotion or maybe switch careers. I think a lot more attention needs to be paid to broadband, and there needs to be more than just platitudes and sound bites. There's got to be real action, and it's been far too long.
Mr. Lopatovsky, do you have a feel for how many of patients in your area lack adequate internet access for telemedicine?
Again, it's sort of a tale of two cities for the market we share. The Lycoming County area, not so much, but poverty does play a role there for some of our people that don't have the wherewithal to be able to afford it. They don't have it. However, when we serve our rural communities, again, up toward the state border, Tioga County, Bradford County, Potter County, it's a serious barrier there. So we found, like others, that our telehealth just exploded during this pandemic. In March, UPMC-wide was doing less than 250 telehealth visits a day. By April, we were doing nearly 10,000 a day. We're not currently at those levels, but a lot of it has developed some stickiness where it's ongoing and something that is used quite frequently by many of our specialists, many of our primary care providers. However, if you don't have broadband, can't do that. So it certainly is a barrier, and it's sort of an issue where the people that need it the most have the least amount of access. So I think of it as sort of like the poor get poorer, and it just seems extremely unfair and unfortunate for these communities we're trying to serve, where it is very, very rural. The area we serve is about the size of the state of New Jersey, but it has the population of Alaska. So we're have a population of about 700,000. So there's a lot of, there's 17 people per square mile in Potter County, for instance. So there's a lot of miles. Our visiting health team, our visiting nurses that do outreach visits, visit all of these counties. They do over 1 million miles a year in travel to visit patients. And they want to get on their computers and log on, unable to. They might want to call the doc and say, hey, I'm at your patient's house, and here's what I'm seeing. I'm a little concerned. They don't have cell service. So those are the kind of barriers that I think much of America, much of Pennsylvania's don't understand that are occurring in these rural communities.
Mr. Kurtz, broadband isn't the only thing needed. Of course, you need a compatible device, and there are other things that are needed for telemedicine visits. Devices to measure oxygen levels, blood pressure. How do telemedicine patients go about getting that equipment and using it? Can you talk to that a little?
Let me just jump on the access bandwagon. I think it's going to become more and more critical for access as this telemedicine thing expands. But just give you an example, we're starting a telemetry program here where we're able to monitor patients in their homes, just as the same monitoring equipment we could do on a patient floor. Now, you can see the advantage to that, especially during this pandemic. A lot of the patients we admit here are only for monitoring. If we could keep them in their home or a nursing home right up to the last minute, we'll monitor them for 24 hours. A lot of them will never have to require hospitalization. Can you imagine how many beds that would free up? But guess what limits us is access to broadband and access, because this takes up a lot of, you can't do it over a cell phone. We have a lot of areas in our area that don't even have cell phone coverage. So, you know, they're taking off the board right off the thing. So the people around the hospital are going to be able to take advantage of this telemonitoring program. Chip knows I've been on this bandwagon since the pandemic started. I think it should be part of a hospital's licensing that says if you're a 50-bed hospital, you should be able to take care of 50 people in their homes at the same as your thing. Can you imagine the impact that would have had on this pandemic, especially in nursing homes? If we could monitor those patients over there, you know, disrupting an elderly person's routine and with dementia, plucking them out of that setting and putting them in our hospital just to be monitored isn't great patient care. But if we can put those monitors in that care, we could double the capacity of the beds in Pennsylvania if we have these in place. But this lack of access to broadband and any basic services in a lot of these rural areas is going to really limit that. And I was interested in Billy's comments. I didn't realize that there was funding for this. It's so frustrating to do it. But to give Karen, this is all part of your vision and your legacy that you left in Pennsylvania. We would have never started these programs or had the ability to start these programs hadn't been for this Pennsylvania rural health model that you initiated under your term here. And honestly, it's transformational. It sounds like we're trying to reduce the volumes in the hospital. We're really not. We're just trying to put appropriate use of the hospital. So we put programs in like palliative care or the frequent flyers that had no other way of showed up in our emergency room, get their medication, get admitted for 3 days, get their medications adjusted and go home. And every 6 weeks that came about with chronic conditions because they had no other way to do it. But under this rural health model, we were incentivized to keep patients out of the hospital. Before, we were making money on that. So we were incentivized to actually do the wrong thing for those patients. Guess what? We take care of their homes, better patient care. And again, we're reimbursed for it under that global model. So that's the plus. Telemedicine is going to be the way of the future. It's just, everybody pointed out, we have lack of access to physicians. You know, physicians, our primary care physicians are already transferring their patients into a telemarketing or a telehospital type model because they can see more, and you know, it's actually better for the patients. It doesn't require a lot of sophistication either. You know, most people have it if they've got access to the internet, and that's going to be the key. And you know, as somebody pointed out, it's ironic, but the population that really needs it most are the ones that are going to be barred from being able to use it because of a lack of basic cable or broadband access in these rural areas. So the equipment isn't bad. I mean, even the equipment we're looking for telemonitoring is not real sophisticated. But you can imagine, again, during this pandemic, you know, one of the biggest things in Caramel is a pulse ox. We'll be able to watch a person's oxygen levels instantaneously. It's going to be hooked into our emergency room. And when we can start seeing them go into a dangerous level, get an ambulance over and bring them in, you know, and do that. But the equipment isn't really that sophisticated. And it's affordable for every small hospital out there. So again, you got to have the connectivity to be able to do it.
Tina, is that the case? Can you talk about the investment you've made at your own facility in telemedicine and you know, what types of care it's used for?
Sure. I don't have the specific dollar amount that we invested to really ramp up our telemedicine when the pandemic hit its early peak, but we did do a lot of transitioning. One of the things, as it was mentioned before, that the lack of broadband made the Zoom type telemedicine difficult in many of our communities. So a lot of our providers actually did telehealth, meaning on the phone. And, you know, it's not the ideal situation, but at least it was still a way to connect the patient to the provider. The US Census Bureau predicts or estimates that just over 75% of households in Ashtabula County have internet access, but it doesn't say how reliable that access is. The southern part of our county is more rural than the northern part. And I will tell you, just from individuals that serve on some of the committees with me, it's unreliable. They could cut out at any moment during, you know, a telehealth visit or a meeting like this. So it's a challenge with everybody. And it was interesting also to learn about the fee on the bottom. I think that resonated somewhere in the back of my mind that I had been aware of that, but I hadn't really thought about how long that had been in place with, you know, basically no action. There was a bill in the Ohio legislature last year that passed the state house, but was never even brought up for vote on the state Senate, that would have been a broadband grant program. That needs to come back around. We need to do something to make this technology that is so great and has so much potential available to the people who need it.
Yeah, and I think we're getting to a point where we need to consider this life-saving because it really is. We can see it in the research. Access is one piece, but so is affordability, because even in rural areas where there have been inroads in increasing access to broadband, it's been twice as expensive as what you would get it in other places. So it truly needs to be accessible and reliable in that people can actually afford it.
Well, what about people using it? Kendra, have you found that there's a struggle to get segments of your patient population to agree to use telemedicine and to do so well enough that it's effective?
Yeah, we were pleasantly surprised. We were able to fairly quickly, push out our telemedicine strategy. We have the systems on our side to be able to do it, and people want to be able to do it, but there's nothing more to be said other than what's been said about broadband, because I was just looking at the data that we use. So I look at Snyder, Union, and Northumberland counties. The hospital resides in Union County. Union County is usually looked at as a little bit more economically stable than the rest of the region. And 51% of people are underserved when it comes to broadband, meaning there's not enough providers, and those that are here are not meeting the speed standards. And it's in Snyder County, it's 46% are underserved, and in Northumberland, it is 48%. So it's not about people having the equipment, knowing how to use it, or wanting to do it. They desperately want to do it, but it's the lack of access to broadband. And so it just all comes back to that. I think we all can do it and do it well if you can access it, and people can't.
John Finnerty is our State House reporter for CNHI. I'd like to give him an opportunity to ask a question or two. John?
Okay, can you hear me now? Okay.
Yes, sir.
Well, it seems like you touched most of the things I want to talk to, and it seems like as far as legislation, it seems like I have to talk about broadband with folks here. So I'll leave. I won't bother you. Moving at the state capitol that you think really needs to be addressed, and anyone who follows that can feel free to chime in.
John, you actually dropped out in the middle of what you were saying. So if you could, or at least I didn't hear it, if you could please repeat it. Sorry about that.
Sure, no, that's fine. Yeah, no, I was going to say, obviously I heard broadband loud and clear. I was just wondering if there's any other legislation that's kind of moving at the state capitol. It's either good or bad, I guess, that you think would really help you. I certainly have heard a lot of talk about broadband. I've heard a lot of talk about telemedicine. Didn't know if there's any other issues that really matter to people. Well, if the answer is no, then that's fine. We'll move on.
No, I was just going to wait for others. I was going to say the answer is definitely yes for Medicaid. Medicaid is federally funded, but it's a state partnership. It's done in partnership with states. And there's a lot of opportunity to learn from the successes of some of the other payment reforms that are occurring in other states. Karen mentioned, some of them. But the legislators there's going to have to be a political will and a legislative ability for state Medicaid to experiment with additional payment reforms. And we can do that right here in Pennsylvania.
Thank you. I guess the other issue is, I know we have UPMC and Geisinger folks on, so I wondered if you could kind of talk through sort of, you look at the map, we obviously have, in rural Pennsylvania, we have a lot of mergers. We have a lot of these large sort of hospital systems kind of taking over large swaths of the state. Can you kind of talk through sort of, is that why that's a good thing, I guess?
Can I answer that? I'm acutely aware of that. We're the only remaining independent hospital in 3 counties now. Surrounded by UPMC and Duke Light Point, which is a for-profit, and Out of the 240 hospitals in Pennsylvania, there are less than 20 of us that remain in that category. Again, according to Karen, 19 of them are in this rural health model, and that's going to be the salvation for me. We're real dinosaurs, and you know, I may be prejudiced, but I still think there's an acute need to retain these small independent hospitals, and you can see that. And you know, I worked for UPMC early in my career, and it's a great organization, but you know, you really have to experience what goes on in a true independent hospital in this community. And you know, again, I think that this country was founded with these small hospitals, and that's what built the health system. And you know, it's hard for me to answer this without being disparaging to the bigger system, but I don't want to be. But I would put up our quality of care of this small institution against anybody out there. And I just look at this. Very passionate about having these remaining hospitals remain independent in the communities. And one of the advantages I have, for example, I don't have any referral patterns. So I can refer to UPMC, I can refer to Allegheny Health Network, I can refer to Geisinger, and we do. But we can make those choices based on where we feel the best care for that patient is. Would I have that ability if I was part of a larger system? Probably not, definitely not. So I can make choices in this institution, you know, based on what I feel is quality of care. And we spread it around. We do that. And I think it challenges these bigger institutions to remain competitive and provide good care to cater to these individuals out there, these smaller hospitals that will feed into them. Again, I think that our cost is a lot lower than what would be provided in some of the bigger institutions. We just don't have the overhead to cover. And again, I think our quality is measured equally as good or a lot better in a lot of cases for these places. But it's a dinosaur, and it's not just a dinosaur in Pennsylvania. It's happening all across the country. And I gave you those statistics, and I think they're actually probably shaded a little bit. I would guess that they're way more than 60% of them are operating at negative margins right now. And you know, every year it keeps going down, and you know, conversations like this are a great platform for us to get that word out that, you know, we employ between the Institute and the hospital 500 people in this area. And, you know, we're looking at the economic impact that these small hospitals have also in that area. And Chip, again, can attest to this. We could not lose 500 jobs out of this area. I mean, it would devastate the entire area. Again, these small hospitals do that. And, you know, sometimes bigger is not necessarily better. I guess that's probably my answer to that.
Well, does someone from UPMC or Geisinger want to explain why bigger is better?
Yeah, I could.
So I don't. Oh, I'm sorry. Go ahead. Go ahead.
Go ahead. Okay. Yeah, I could speak a bit about our journey. You know, we joined UPMC 4 years ago. At the time, you know, we were doing well. We were one of the first ACOs in the country in 2013. We saved Medicare $3 million. We had 100% quality scores. Those numbers are both Medicare numbers. So it was a shared savings plan. Our ACO partners didn't meet this shared savings threshold. We saved $3 million here, and we were left with no shared savings. So we worked very hard to send patients back home from the EDs. We worked hard in investing in medical directors and providers in the nursing homes. So we had those avoidable ED visits that didn't become avoidable admissions. We had nurse navigators in our primary care practices. So we would work very hard for patients not to go to the ED again to avoid those admissions. At the same time, we were buying robots for our EDs. We were a Cleveland Clinic affiliate site for our Heart and Vascular Institute. And we wanted to invest in an upgraded IT system, and the price tag for that would be $75 million. So we saw the handwriting on the wall. Costs are going up. We're doing good quality. We're not being rewarded for our quality. What would be the logical next step? And we decided we needed those economies of scale. We needed to be part of a bigger system. And ideally, someone with a population health product like a health plan, so we could have some of those internal discussions with part of our family would be a health plan versus always sort of debating whether we saved enough or where we can get some shared savings. So here we are a little over 4 years after that happened. And, you know, I would say that we've improved the quality of care, especially to, you know, we're a very rural market. I spoke of Potter County. We have a Hillman Cancer Center now the same as they have at Pittsburgh in Potter County. It's just something that is very much state-of-the-art care in a very rural community. We have a liver clinic here now at Williamsport in Lycoming County, where patients could have their preoperative care and postoperative care for those liver kidney transplants. They still have the transplants in Pittsburgh, but what a savings that is, rather than have our patients travel. So they're just a couple of the improvements that we've made as we've continued to invest in the community. I would tell you that we've done a lot of upgrades to our rural hospitals. We've added some hospitals since that time that again, we're failing and struggling. So that's kind of a bit about our journey since we've been part of the UPMC system.
Yeah, I think I'd frame the question as a larger question, not as it good or bad, but really, what does appropriate rural health care look like across the country? So the global payment model that we were talking about was designed to do exactly that. Whether you're part of a system, Geisinger, I know UPMC is participating in the global payment model, and Geisinger is participating in the global payment model, really for the reason to be able to reshape what we're doing in rural communities to improve access to, as was so artfully described before, really incentivize value-based work with value-based payments. So I don't think the question, is it good or bad? I think independent hospitals that want to remain independent should have a way to do so. And the global payment provides an opportunity to do so. I think those hospitals that, again, was artfully articulated, that want to go into a larger system and have that opportunity, the question is really the same. You're not going to build a tertiary care center in the middle of a rural community because you don't have access to the physicians, regardless of your resources. You don't have access. Very difficult to recruit. You have other issues associated with payment mechanisms if you're not involved in innovative payment. So our question really should be not what is the ownership structure of the hospital. It should be, how do we deliver rural health care to improve the health of our communities?
So I have one other topic that I'd like to address, and that's access to medical specialists. Kendra, how about we start with you? Can you talk about, well, let me talk anecdotally. I know someone who had to wait about 6 months for a dermatology appointment. I myself was probably a little over a month out for a specialty appointment myself. What is your solution to addressing the need for specialists, and what are the specialties that you are finding in your area that are most in need?
Sure. I think I can piggyback almost off of the previous conversation where, Evangelical is one of those hospitals, as was referenced, that's still an independent hospital in Pennsylvania, when you're almost an anomaly when you are independent. And you're also an anomaly if you're a strong entity. And Evangelical finds itself in a position where it's pretty strong. And we happen to be in an area geographically that is, has very strong tertiary care partners. So, we're very close by Geisinger. We're very close by UPMC Susquehanna. And so, for me, we work closely with those individuals all the time. And so you put the patient first and what's in the best interest of the patient, and it's to figure out how best to get them their care. And so I'm never going to be all things to all people as an organization, and I'm going to work together with my tertiary care partners, for lack of other word, on how best to get that care. So we do our best to recruit specialists, and we've done quite well in certain areas, but there are areas in which you struggle. And the more you get into even subspecialties, the harder it is. So we're going to work more closely with those tertiary partners to figure out how we can give them, how we can get our patients access to those specialties. So we try on our own to recruit as best as we can, but you get into situations where you're recruiting and physicians want call coverage from one another. They want backup support. So you end up negotiating with your tertiary partners to say, hey, I've got this guy, but is there any way you can cover me, the 3 other weekends in a month because a person only wants 1 in 4 call coverage. And so you're really forced to figure out ways in which you can work together. And I think we've done that very well in staying independent and being strong in the things that we're good at, but working with our tertiary partners to meet the needs of the community. And, you know, as a community hospital, you're constantly challenged by access to capital for all the things that you need to do. So you really are forced to look at unique ways in which to work with people and your partners to just make sure your patients are getting appropriate care. So, you know, we can all go through the specialties that are hard to recruit. I would argue in certain specialties, it's hard to recruit even if you are one of the big players in the market. There's just not, you know, there's certain specialties that are hard to find providers for. But, you know, that's kind of how I look at it, is I am never going to be all things to all people. So I've got to work with other people to get my patients to those facilities.
Tina, same question to you.
We have the blessing to be an affiliate of Cleveland Clinic. We are not a wholly owned hospital, but we do have that formalized management agreement and strong connection. We're very successful in recruiting specialists to Ashtabula County. I think carrying the name of affiliation of Cleveland Clinic helps us with that. The challenge is there's so many of those specialties that we have where there's one provider. So as it was mentioned, call coverage. Our medical staff bylaws say you take 10 days of call per month. Okay, that's 20 to 21 days where we don't have a urologist on call. So somebody comes into the emergency department and that urologist is not on call, we are shipping that patient out, primarily to Cleveland Clinic, but there's always patient choice. It was also mentioned about not being all things to all people. We've done a lot of collaborating with outside organizations. One of the other desperate needs in Ashtabula County has been dental care, and specifically dentists that would take Medicaid. Not feasible for a hospital like us to employ our own dentists. But there is an institution called Cleveland Dental Institute that was interested in coming into the market. We had purchased a former shopping plaza across the street because we are so crunched for space on the main hospital campus. And we're able to lease them space. They're providing a need to the community that we can't meet personally. We're receiving income from their lease payment every month, and a community need is being met. You know, the other thing that I would say is that affiliation with Cleveland Clinic does give us the opportunity to have some of those specialists employed by the clinic, but stationed out here. Our cardiologists are all Cleveland Clinic cardiologists. Our radiologists, they're on site every day, but then we also have the Cleveland Clinic radiologists off-site that are doing the reads in the evenings. We have some specialty clinics for pediatric subspecialties, cardiology, endocrinology, pulmonology, that come out on a once a month or twice a month basis because there's a need, and we have transportation issues, not just getting to appointments in Ashtabula County, but patients getting to Cleveland. But we don't have enough capacity to hire that specialty, very specific specialty in our community. So we're able to piggyback on a hire at Cleveland Clinic, bring them out for a day or two. That helps us, but it is, you need to find ways, as it was said, work with your other partners in the community and be creative in how you meet those patient needs.
And speaking of partners who I work with, Chip, John, we have Bill Bowman, my managing editor, and Dennis Lyons, our editor, also on the call. Do any of you have any one last question to ask? We're running at about 50 minutes right now.
Yeah, this is Dennis Lyons. I do have one, getting back to telemedicine. I would assume it's a challenge because a lot of your patients are older. A lot of your patients, I just got a note today I had issued an invitation to connect with me by email if you wanted to be involved in a program we run here. And I got a scribbled note in the mail a few days later saying, I don't use computers. I don't use email. How am I supposed to be part of this program if I am not into technology? Is that an issue that you guys are challenged by and have to try to figure out?
So what we found out during the pandemic was that we always thought that was the case, is that it would be, we're launching a major digital strategy over the next 5 years. And we were always concerned that the composition of our communities, which is predominantly older, that we would have a very difficult time. And oddly enough, during the pandemic, when we surveyed patients after they had the telemedicine experience, they were very, very favorable. And now it's hard to tease out, were they favorable because they didn't have access to a physician? We were able to give it to them virtually. But we have seen a really impressive adoption by our elderly patients. Now, we still have, I'll use the example of scheduling vaccines. We offer an online version or a phone number to call, and many elderly people elect to use the phone because they don't have access to a computer, or they're not on email, or they just find it difficult to navigate. But as far as virtual health goes, we were pleasantly surprised that we had the uptake we did in the elderly population.
Thank you. Did I understand someone to say, though, that there's a way for on telemedicine appointments for things like blood pressure and heart rate to be monitored? I thought I heard that. So how does that work?
Yeah, we're starting a demonstration project here with it. We've got the equipment on board, and we're training our home nursing. And matter of fact, we're actually contracting with our local paramedics to help hook these leads up when they go there, because it's the same equipment they virtually use on ambulances. And those paramedics are sitting around waiting for calls, and this gives them something to do while they're out there doing it, provides revenue for them. But our home nurses are taking the lead on it. It's virtually, it's the same thing that you see in an ambulance. You see them putting those leads on patients and all that equipment. It just does it in their home. One of the things that we're implementing here about the older population and technology is we're starting to teach our palliative care nurses and our home nurses, when our primary care wants to put an elderly patient on technology, we'll send a nurse out and show them how to use an iPad or an iPhone and educate them. Once they do that, they're good. They're not going to do anything else with that, but they'll be on it, that they'll have the iPad tuned in, ready to go. But we're encountering that too, because you think there's a lot of support systems out there, but there's a lot of people that do still live alone and don't have access to the technology, but just don't quite know how to use it. And we thought, what better source than to use our home nurses? We're fortunate to have quite a few primary care physicians employed by us. So when they do get somebody that's technology challenged, we will send somebody out to teach them how to do that. But I'm telling you, this is a bandwagon. I'm telling you that remote telemetry is going to be a big thing in the future. It's telemedicine on steroids. And if nothing else, this pandemic showed there's a real market, there's a real need to have that out there. It takes care of, somebody just talked about specialty care. You can do a lot of specialty visits if somebody had that monitoring equipment on them. You could have one specialist do a lot of televisits if they had that monitoring equipment available to them. Even with a home nurse present, you could hook it into, you have a neurology visit very easily at a person, a cardiology visit very easily at home. But they can't, you need some specialists require hands-on. But that hands doesn't have to be that physician's. It could be one of these either mid-level or one of these nurses could be there while that physician is doing that consultation with that patient.
Interesting. Thank you.
I'd like to thank you all for your time today. We really appreciate you joining us. Take care.